Hello, everybody. Okay, let's start this session of the Journal Club of June. Unfortunately, Ruben cannot join us. He's a little bit indisposed, but I'm sure we will make a nice conversation and we will make him proud. Today we have Dr. Karim Ben Ali, who joins us since when? April? When did you join us? Yeah. And he's a physician and expert of catheter ablation and in general treatment of cardiac arrhythmias. And he will present us his last paper, meta-analysis, for which the title you can see it here in the shared screen. And without further ado, I will leave the stage to Karim for his presentation. And I thank him already for the time that he has dedicated to us.
Oh, good morning, good afternoon, everyone. Is it okay for the sound?
Yeah.
So it's a pleasure to be here with you today at the Journal Club. And I'm Dr. Karim Ben Ali from Saint-Etienne University in France. And I'm also a new research fellow here at the Lyric Institute in the team of Michel. I would like to thank Guido for this kind invitation to present a work I performed with the Montreal Heart Institute team about the temporal trend of the complication of catheter ablation of AF. I don't know, maybe the majority of the audience here are basic researchers, so maybe I hope it will not be a too clinical based presentation. I will try to be clear if there are any problem, or don't hesitate to interrupt me for any question or anything not clear. So yeah. So here my disclosure, nothing special with this topic. And as you are probably mainly a basic researcher, I did some slides about the clinical management of AF. And briefly, when regarding clinical management in AF, the first point and the first axis, I think the most important one is the prevention of stroke. In this patient, the risk of thromboembolism is really high, and by prescribing anticoagulants with VKA in the past and now with direct anticoagulants, we have the possibility to significantly decrease the risk of morbidity and also mortality in this population. So I think it's the most important point. The second axis is the control of the heart rate of the patient, and in patient with in AF, it's really important to control this heart rate because this rate is associated with the symptom burden. This fast rate are also associated with heart failure hospitalization and also with the development of tachycardiomyopathy. So this is the second axis. And the last one, the rhythm control approach. We have to pass from an AF rhythm to sinus rhythm, we have several tools to perform this control to this rhythm control strategy. We have the electrical cardioversion, but it's just a band, and it doesn't help to treat the pathological the pathophysiology of AF, but it just convert to sinus rhythm. We have antiarrhythmic drugs, and we also have catheter ablation, and we are going to talk about this rhythm control approach with catheter ablation for AF. So the first question maybe to answer is when to perform catheter ablation for AF. And if you have only one thing to remember in this slide is that at the current time we only perform catheter ablation in symptomatic patient. Yeah. So the patient has to be symptomatic, but also we use it usually in a second line, so after a failure of antiarrhythmic drug therapy. So it's the best class of recommendation. It's class 1 when the patient has a failure of antiarrhythmic drug, but we can also perform the catheter ablation as a first line strategy, and it's a 2A class of recommendation. And we also perform this kind of ablation sometimes in asymptomatic patient, but only when there is a tachycardiomyopathy and we want to improve the LVEF of the patient. How to perform catheter ablation for AF? Since the seminal work of Michel Essager in 1998, we know that the vast majority of the triggers at the onset of AF episodes are located in the pulmonary veins. And so we do, to eliminate this trigger, we do an electrical disconnection of the pulmonary vein from the rest of the left atrium. We do lesion with radiofrequency or cryoballoon. I will explain it a little bit later, but by disconnecting this pulmonary vein from the left atrium, we have a good efficacy on the symptom of the patient. This is called the pulmonary vein isolation, and this is the main strategy, because in the guideline it's only recommended to do pulmonary vein isolation, and all other strategy that you can see in the literature, it's for persistent AF ablation mainly. It's not at the current time. It's not a good class of recommendation, and pulmonary vein isolation is the cornerstone of our approach for catheter ablation. It's the pulmonary vein isolation allow the elimination of the trigger, as I mentioned earlier, but also the right antral isolation of the pulmonary veins allow to eliminate the substrate near the junction between. And this modification is really important for the elimination of reentries. And also, it's not very clear, but also this pulmonary vein isolation can allow us to do a modulation of the autonomic system with vagal denervation, and we can see during pulmonary vein isolation a lot of vagal response in patients. So maybe these are the mechanism behind the efficacy of pulmonary vein isolation. So the two main tools to perform the pulmonary vein isolation at the current time are radiofrequency ablation. So we have a lasso catheter, as you can see here in the vein. This lasso catheter allows us to record the signal from the electrical signals from the vein. And we have a tip catheter, as you can see here, and point by point, we are going to deliver the radiofrequency, and we are going to turn around the pulmonary vein and to try to disconnect this vein from the left atrium electrically. The other energy to perform this is the cryo energy. So with cryo balloon, as you can see here, we have also a lasso in the vein. So the lasso can record electrical signals, and we have a balloon which is impacted in the vein to occlude the vein, and we deliver cryo energy to freeze the vein and to disconnect electrically the vein from the left atrium. These are the two main energy used, and the title of this slide, Fire and Ice, is also the title of a very famous trial in electrophysiology. The Fire and Ice trial has shown that cryo balloon is not inferior and is as safe as radiofrequency to perform catheter ablation for AF. So these are the two main technology at the current time for performing a catheter ablation for AF. The epidemiological context, it's important to note that, and you probably may know that AF is the most frequent sustained arrhythmia that we deal with in clinical practice. The problem is not new, and the problem is probably going to get worse because with the increasing prevalence of cardiovascular risk factor, AF will probably become a major public health challenge in the next 30 years. A second point here important to note is that not in 30 years, but now at the current time, catheter ablation is already the most frequently performed catheter ablation around all the world in all EP labs. So it's the most frequently performed ablation in electrophysiology. And the third element, and I think it's really important to capture this evolution in the indication of catheter ablation for AF. We are slowly moving from a second-line ablation therapy, so after antiarrhythmic drug, to a first-line ablation therapy. It's really common now to offer this therapy as a first line to the patient, and maybe in the next 10 years to a therapy that we are going to offer in asymptomatic patients. We are not sure now, but it's the current trend, and probably in the future, I refer you to the beautiful works of Jason Andrade, an expert in this field, that we are slowly moving to an increase in the indication of catheter ablation. From that perspective, in addition to the efficacy of the procedure, it's important to know if this procedure that we are offering to an increasing number of patients has a safety profile improving over time or not. So we have some evidence from the literature, and between 2000 and 2006, here it's a beautiful meta-analysis of the team of Prash Sanders in Australia. And they showed that between 2000 and 2006, the complication rate of the procedure has decreased from 4% to 2.6%. Similarly, in the next years, here it's a beautiful registry from the Cleveland Clinic, a big registry, and it seems that this safety profile has continued improving over time. But it's also important to note that in the literature, there are also conflicting evidence. And here I show you two surveys of Capato in Italy. Capato, he works in Italy. And these two surveys maybe suggested that the complication, the safety profile of the procedure could have been stable over time. So here are several things. The first is that we have conflicting evidence about this trend in the safety profile, and also we have very few data about the more recent temporal trend of this safety profile over the period of 2018 and 2022. When we decided to perform a meta-analysis with Laurent Macle in the Montreal Heart Institute, one important point was to decide which study we were going to include in the meta-analysis, because as you probably may know, the reported complication rate of the procedure in the literature are markedly variable. And these rates can range from 1% to 8%, which is almost a multiplication by a factor of 10. And clearly, you cannot say to a patient, yeah, your risk with this procedure is about 1 or about 10%. This reported complication rates are mainly depending on the study design. And you can easily understand that between a survey, a retrospective registry, or prospective cohort, or a randomized trial, the authors will not report the complication in a similar way. And here I show you a beautiful subgroup analysis in the previous meta-analysis that I showed you about the team of Prash Sanders, and comparing studies retrospectively defining the complication or prospectively defining this complication. The difference was almost 1%. So it's really, really critical to choose a good methodology. And we choose to include only randomized trials because it's probably the more reproducible methodology, the most reproducible methodology regarding the report of this complication. Regarding the inclusion criteria, so as I mentioned, we included RCTs between 2013 and 2022. This period of time was split into two periods of 5 years. We included only RCTs involving first AF ablation procedure, only with radiofrequency or cryoablation. So we did not include pulsate field ablation. We did not include hot balloon or laser balloon, which are other technologies, but not really commonly performed. And with at least 1 year follow-up. When we performed the search in PubLine and Medline with this criteria, we found more than about 1,500 studies, but only 89 randomized trials met the inclusion criteria. And here you have the diagram, the flow diagram of the meta-analysis. Briefly, for the characteristic of the included studies, we had almost the same number of studies in the two period of time. The vast majority of trials were multi-center trials and involving more than 100 patients, involving mainly paroxysmal AF and radiofrequency ablation. When we look at the risk of bias of this trial, and we used the Cochrane tool for the assessment of the risk of bias, and the majority of these RCTs were considered to have a low risk of bias. So it was really good for regarding the quality of the reporting. Another critical point in the methodology was to to decide which complication should be classified as a severe or non-severe complication of the procedure. It was maybe a little bit subjective, but we decided to class as a non-severe complication all the procedures that did not prolong the hospitalization, and all other procedures all other complications were considered as severe, from severe vascular complication to death. I will spare you and not read all this list now. When we look at the result on the whole period, so from 2013 to 2022, the overall complication rate was 4.5%, and the rate of severe complication was 2.4%. The main complication were vascular complication, and then pericardial tamponade and effusion, and it was quite consistent with the literature on the subject. The mortality on the whole period was 0.06, and it was also quite consistent with the rate described in the literature. But this is not the main result, and the most important thing is when we compared the two period of time, and we observed a significant decrease in the rate of overall complication from 5.3% to 3.7%. Interestingly, this significant decrease in the rate of complication was driven by the rate of severe complication, while the rate of vascular complication, which are the most frequent one, was quite stable over time. Similarly, pericardial tamponade and effusion and stroke TEA, the second most frequent complication, were also quite stable over time, and the rate of death also was stable around 0.05. Secondly, we looked at the factor possibly influencing this risk of complication in this population, and interestingly, no demographic factors, so neither age, BMI, the male-female ratio, the type of AF, or the presence of heart failure patient. All these factors did not seem to influence the complication rate of the procedure. Similarly, the device, so cryoballoon ablation or radiofrequency ablation, and the ablation strategy, so PVI alone or PVI and an additional strategy beyond PVI, all these strategy did not influence the complication rate of the procedure over the 2 period of time. The only independent factor associated with a decreased rate of complication was the publication year, going in the sense of an improvement of the safety profile of the procedure. When we look at the distribution of all these complications, as I mentioned earlier, the most frequent complication were vascular complication, with half of the complication, and the second most frequent was tamponade and effusion, and in tamponade and effusion, more than half of the patient needed a drainage, either pericardiocentesis or surgical drainage. Then came the stroke and transient ischemic attack, and far after all the other complication. Among all the RCTs, 9 deaths were reported and related to the procedures. And among these 9 deaths, 6 were related to an atrioesophageal fistula, which we know is a dramatic complication of the procedure, 2 to massive stroke, and one death shortly after the procedure without any obvious cause. Regarding the limitation, I think the first one and the most important one is the fact that for this meta-analysis, we included only randomized trials. And we know that randomized trials involve mainly high volume centers. It's not low volume centers that are included in randomized trials, and it's also usually experienced operators. So maybe we can imagine that this complication rate that we describe is not representative of low volume centers and less experienced operators. However, in the literature recently, in the JACC, there is also another paper. It's a registry, so it's not a randomized trials, and the rate of the main complication was quite similar with our results. So it doesn't seem to be a problem of high volume or low volume. We we choose to only two ablation devices, so radiofrequency and cryoballoon, and so our results are probably not extrapolable to other devices. And I mainly talk about PFA, which is probably a game changer in the next few years in ablation. At the current time, radiofrequency ablation and cryoballoon ablation are the most frequently used device for. So at this time, it's really important to know the safety profile, even if in the future pulsate field ablation can be a dramatic game changer. And another important point is that in the vascular and overall complication rate, we had a significant heterogeneity with the E2 index very high. However, as I mentioned earlier, the results were mainly driven by the rate of severe complication. And when you look at the heterogeneity index of all the severe complication, you can see that it is significantly lower. So maybe it's not so important limitation for these results. What can account for this improvement? Regarding tamponade and effusion, maybe we can imagine that the introduction of contact force sensing catheter can explain a part of this improvement, and also the use the common use now of electroanatomical mapping system. For the strokes and transient ischemic attack, the use of the new anticoagulants, the direct oral anticoagulants, instead of a VKA, as shown in the literature, a great improvement in the rate of stroke during the procedure. And also, operators are more experienced now with the management of the per-procedural anticoagulation. Regarding vascular complication, echo guidance is slowly becoming the gold standard, and it is clearly a game changer regarding vascular access in this population. We ablate patient for the symptoms. It's not. We cannot accept to have vascular complication because we don't use echo guidance. So I think it's slowly becoming a gold standard, and it's really good for this kind of procedure. And regarding some dramatic and very rare complication like atrioesophageal fistula, the use of ablation for index. So we have some indexes that guide us for the duration of ablation, and now it's common practice to use these indexes. And also the operators now are really aware about this rare complication but dramatic complication. Regarding the important direction in the future, I think, it's important to know that the safety profile has improved and it's really good, but also we have to investigate which patients now are at risk for the different complication. And maybe we can imagine in the future a personalized approach for the different population undergoing a catheter ablation with different risk factors for different complications. Also, the generalization of the best practices, as I mentioned earlier, the echo guidance for vascular access, and also the echo guidance for transeptal puncture, I think in the next years, and we are waiting for expert consensus from the HRS, and probably in the future it will be mandatory to do this echo guidance for vascular access and transeptal access. And with all these elements and the improvement of the safety profile of the procedure, we are going toward a democratization of this procedure, and it's really important because if we want to treat this increasing number of patients, this huge volume of patients requiring AF ablation, it's really important that the procedure could be democratized, and with all these elements, I think a lot of medium volume centers and low volume centers can start with this kind of procedures. As a conclusion, we can say that the complication rate and the mortality rate of the procedure is really low, and we have a lot of evidence now to say that to the patient. And also the safety profile of the procedure is improving and has improved a lot during the last 5 years. And it's mainly driven by the rate of severe complication, which is a very important point because we can manage easily non-severe complication, vascular or chest pain and all these things. These are not really important issues, but it's really important to know that these severe complications are decreasing over time. And further studies are still needed to clarify the demographic and procedural factors that are associated with the different complications, and maybe to have a personalized approach in the future for the different populations.
Thank you very much, Karim, for this very detailed, very interesting presentation. Personally, I'm a geek for going back to the basics and remind us why we do certain things in a certain way and why we measure efficacy and safety in a certain way. So I would like to, I have some questions, but I would like to leave the floor to the audience in case you have some questions. There's questions in the chat. So Costas is asking, do we know the reasons of the two major strokes that were reported in the ablation group?
Thank you for this interesting question. No, unfortunately, in these two trials, it was not reported. We know that these patients are at risk of stroke. Usually, it's very small strokes or transient ischemic attack in the majority of these patients. But yeah, two patients died, and I think in one it was an ischemic stroke, but with an hemorrhagic transformation, and the hemorrhagic transformation led to the death of the patient. And the other one is what it was not reported if there was a particular cause for this stroke. Yeah.
Any other question?
Yeah, I also have a quick question. Yeah. Thank you very much. I thought the overall talk in the beginning was a really nice overview, and with a really important study that you presented, I think it's really great. It's really great to see the clinical side of things. And with that said, I think it's interesting you're mentioning this difference between high volume and low volume centers. And so for me as a basic researcher, what really is the difference, do you think? Is it the technology that the different centers have at their availability, or is it the skill of the different clinicians? Or can you give me a little kind of perspective into what these differences might be?
Yeah, it's a really interesting question, and it's funny because with Costas, my friend Costas, who asked the first question, we had this great discussion a few days ago, and I think all the elements account for this difference, because usually in low volume centers there is a difference in the skill of the operators. Clearly, it's count, and there is now a threshold in the guidelines to perform some ablation procedure, VT ablation procedures, but also AF ablation procedure. We know that when the center has less than 50 procedure per year, the complication rate is significantly higher. But also, I think you are right, it's also a problem of technology, because as Costas explained me, yeah, also in the high volume centers and the centers involved in RCTs, usually you have always the best technologies regarding everything, and also for the management of the complication. If you have a tamponade in a low volume centers without surgery in this center, it will not be managed like if you have a tamponade in a university centers, and you can have surgery in the 30 minutes after the tamponade. In a low volume centers, you must be transferred to another centers, and clearly it's not, maybe it can represent a loss of chance, but yeah, it's not clear why, but yeah, it's in part the skills of the operator, and also the experience of the centers, and the ability to have the best technologies and to have surgery really, really fast, and this thing maybe.
Yeah, just to give some commentary as an addition to this answer, it's not weird in small volume centers, at least in my experience. I know a couple of cases where you have not like we might have here professional electrophysiologists who are trained for this, and they are specialized in this, but sometimes you have interventional cardiologists which are trained to do catheter ablation. So of course, their main concern is their main expertise is in interventional cardiology, and then they contribute because there is a need, and they contribute to catheter ablation. And this can, although I don't have any confidence data on this, This can also give us an idea of why small volume centers have a higher rate of complications typically. But I have just a question for you, Karim. But in your experience as let's say a young electrophysiologist, is the what contributed more? Because it looks to me that really with thermal ablation we have reached our plateau, and it's really good that we are going backwards because we can manage better severe complications, and the rest is basically agreeing on a series of best practices. What is what for you? Which one is the best contributor? Is it the technology that has improved it and it has made your life easier, or is the experience of your predecessors? Because, for example, in the Czech Republic, we had one expert electrophysiologist who taught 5 people, and these people became better than him very fast, even if we didn't have the best of the best of the best technology. So what is your opinion? Is it like practice and teaching better, or is it technology?
No. Again, I think it's both, but if I have to pick one to choose one, I will say that the improvement in the technology has been incredible since 5 years, and now with the pulsed field ablation, it will be a new game changer. But since 5 years, 10 years, we have seen so much increasing technology appearing in the cath lab, and contact force sensing for the first time. We ablate in the left heart. Imagine that during the first years of catheter ablation for AF, we ablated in the left atrium without irrigation, with a very high risk of stroke, very high risk of pop, steam pop, and all these things, and the generalization of irrigation, the generalization of electroanatomical mapping system, the generalization of contact force sensing. All these things for me are really, really, really important for the improvement of the safety profile. And also the skills of the operators are really important. But even if you have a really, really experienced operators, if you give him bad tools, a non-irrigated catheter or non-contact force catheter, I think he is exposed to a significantly higher rate of complication. So if I have to choose one, I will say the technology improvement is really critical for this improvement in the safety profile.
Thank you. Yeah, it's an interesting point of view. You mentioned before that we might at this point, since we have plateaued somehow. We are improving in some areas, but we are keeping it constant, at least for these large volume centers. You mentioned personalization at some point. Without electroporation, for me, it's a bit, without going to persistent ablation or very, very complicated case, persistent atrial fibrillation, very complicated case, it's difficult to imagine what kind of personalization, for example, do you imagine for paroxysmal AFib?
It's talk about personalized approach now in medicine, but yeah, I think in some points on AF ablation it can be really useful. And for example, regarding per procedure anticoagulation of the patient, we use exactly the same protocol for every patient, but we don't know if all the patients have the same susceptibility to strokes, and the patient, whether the patient is on VKA or anti-E2A or anti-10A, we use exactly the same protocol, and we monitor the anticoagulation with ACT, but we know that ACT is a really, really, really bad surrogate of the anticoagulation level of the patient. And some teams now try to find some new protocol because we know that ACT in the presence of VKA or in the presence of anti-2A doesn't work the same way. It's completely different. So why to apply exactly the same protocol in all these patients? In an obese patient with VKE, why to use the same protocol in a very very tiny person on anti-2A. It's hard to believe that all these patients need exactly the same parablation protocol for anticoagulation, for example. And also in centers, I'm talking about anticoagulation, but it's the same for maybe transeptal access. In France, we don't use echo guidance for transeptal access, but we know that in some patients, the transeptal access can be really, really, really tricky. We know this kind of patients. So redo procedure or trido procedure, or in patient with really dilated atrium or with some displacement of the heart in the torso, we know that these patients are at risk. So maybe we can personalize this approach in this patient by organizing the availability of transesophageal echography or ICE catheter for the transeptal. And I mean all these things in terms of personalized approach, because we have exactly the same approach in the 1,000 patients that we do in the lab. So maybe there are some little things that can vary from patient to patient and that can influence the complication of the procedure. Yeah.
But yeah, we need more work on this. Clearly,
gap in knowledge in this field. Yeah.
Thank you. Is there any other question? No. Okay. Nobody's launched. I'm thinking if I have something else. It's going to be interesting to see what happens with PFA. PFA is relatively young as a technique. It's making its first step in the clinic, and the idea is that the inexperienced operator will go to 4% complications. I mean, most of these things, especially the tamponade, no. And we know that without contact sensing on these catheters, we might have more complication in this sense. But at least there is no chance of esophageal fistula, vascular complications, subclavian access or radial access. Do you have an opinion on this compared to femoral access?
We usually perform
certainly is the best way to access the left transeptal. All the tail for transeptal is perfect from femoral access, and we do sometimes AF ablation from the subclavian access. It's really, really rare. It is usually in some congenital disease without any stable access from the femoral. Like it's really, really rare, and the transeptal is really, and in some parts it can be also challenging. So no, it's not. And the radial access, I've never seen any publication with. Yeah, maybe. Yeah, but yeah, subclavian access, it's only for my opinion for some congenital patients, but not for the common condition.
But you don't have any more anatomical references.
Yeah. And regarding PFA, I think PFA regarding safety, it will be really, really, really interesting, but it will probably decrease the rate of atrioesophageal fistula and maybe phrenic nerve palsy, because it's a very specific ablation energy. It's not a thermal energy, it's a very specific to cardiac tissue energy. But atrioesophageal fistula and phrenic nerve palsy are already really rare complications. So probably we are going to decrease the rate of this complication, but I don't think that we are going to have a significant impact on the overall rate of complication, because the main complications are related to vascular access or to transeptal puncture or the risk of stroke because we are in the left atrium, but it's not related. I think the global rate is related to this complication and not to atrioesophageal fistula. It's really, really rare complication even now. But it's really important to improve regarding this complication, because as you have seen, among the 9 deaths, 6 were related to atrioesophageal fistula. So even it's if it's rare complication, it's dramatic complication, and all the patient will lose are usually related to this kind of complication. And it's really, really critical to improve on this topic.
Thank you again. And if there aren't any questions, I think we will adjourn at after the summer. I don't think we have a speaker yet, but I'm sure everybody is happy that I'm not bothering everybody with metabolism, but maybe soon. We'll see. Okay, thank you, Karim, again. Thank you, everybody, for participating actively in this journal club, in this session. And I wish you a nice afternoon and end of the day. Okay, take care.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
Bye.